I work nights at St. Mary's General Hospital, a 300-bed facility that's been serving downtown Chicago since 1952. During day shift, it's organized chaos. But after 11 p.m., the hallways stretch longer, the fluorescent lights flicker more, and every sound echoes like a warning. The emergency department where this happened is on the ground floor. Built in 1952, it has that institutional smell, disinfectant mixed with something older, something that won't wash away. The trauma bay has 6 beds with ventilators that should only activate when patients need them. Should being the key word. During night shift, we run with minimal staff, 3 nurses covering 20 beds. The automated monitoring system tracks everything automatically, so when alarms go off, there's usually a medical reason. Usually. I was checking medication charts when the ventilator in bed 4 started cycling air in the empty trauma bay. At first, I thought electrical malfunction. In hospitals, equipment malfunctions happen. But the ventilator had no power cord plugged in. The machine was running full respiratory cycles without any patient connected. I checked the circuit breakers and found all power switches in the off position. The ventilator's display showed vital signs: heart rate 72, oxygen saturation 98%, respiratory rate 16, as if someone invisible was breathing steadily in the empty bed. I documented everything: unplugged power cord, switched off breakers, phantom vital signs. According to hospital protocol, I should have called maintenance, but the readings showed a perfectly healthy patient who wasn't there. The patient monitor suddenly flatlined with a piercing alarm, then immediately returned to normal vitals, as if someone had just died and come back to life. Over the next 2 weeks, the incidents intensified. What started as one ventilator became multiple machines activating simultaneously. I began documenting everything with my phone, but the supernatural presence seemed to know when I was recording. The temperature in Trauma Bay 4 would drop exactly 15 degrees whenever the phantom patient appeared, creating visible breath clouds under the fluorescent lights. Other staff reported similar experiences. Nurse Martinez mentioned hearing whispered medical terminology from empty beds, and Dr. Kim had witnessed IV pumps dispensing saline into thin air. The pattern was always the same: medical equipment caring for invisible patients. During my rounds, the defibrillator suddenly charged to 200 joules and discharged into empty air, the shock paddles floating 3 feet above bed 4 before crashing to the floor. The most disturbing escalation was when all 6 trauma bay monitors synchronized their alarms. During 3:33 a.m., every machine displayed identical flatlines simultaneously while I was alone in the department. This violated basic electrical principles and created an overwhelming cacophony of death alarms. I felt cold fingers touch my shoulder while reviewing the synchronized flatlines, but when I turned around, only empty beds stretched behind me in the flickering fluorescent light. I started tracking the supernatural pattern using a handwritten log. The activity followed a precise schedule, always between 2:47 a.m. and 4:15 a.m., always affecting Trauma Bay 4. The hospital's digital systems recorded impossible data suggesting a patient who existed only electronically. Security cameras showed my interactions with empty beds, but the thermal imaging revealed a human-shaped heat signature lying in bed 4 during every supernatural event. I consulted hospital records and discovered a disturbing history. The Trauma Bay had been the site of a multiple casualty incident in 1987 involving a drunk driving accident. Previous incident reports mentioned similar equipment malfunctions that were officially dismissed as electrical problems. Every night I worked, I felt watched during my documentation. The supernatural presence seemed aware of my investigation, causing equipment to malfunction whenever I got too close to the truth. The breakthrough came when I accessed archived patient files and found crucial evidence. EMT Sarah Chen had died in bed 4 during the 1987 incident. Her final report described her desperately trying to save multiple trauma victims, but losing them all due to equipment failures. While reading Sarah's file, every monitor in the trauma bay suddenly displayed Sarah Chen, code blue, before immediately returning to normal standby mode. When I reported the supernatural evidence to Charge Nurse Patterson, her response was immediate dismissal. Supervisor Williams insisted the incidents were stress-related hallucinations and warned me about professional consequences of spreading paranormal claims in a medical facility. After the official denial, the supernatural activity tripled in intensity. Every piece of equipment in Trauma Bay 4 would activate simultaneously whenever administration walked through. Hospital policy prevented paranormal investigation, but the supernatural activity was affecting patient care and staff safety. Medical equipment continued impossible behavior despite multiple maintenance inspections and complete electrical system replacements. The entity's reaction to institutional denial was protective anger. Sarah's presence became more aggressive, causing equipment to spell out "help them" on multiple monitors whenever administrators ignored the supernatural evidence. The administration's denial only intensified the supernatural consequences. Escalated activity suggested Sarah was frustrated by the lack of recognition for her continued attempts to save patients. A real trauma emergency forced a direct encounter with Sarah's spirit. I was treating a car accident victim in bed 4 when the supernatural presence joined me in saving the patient's life. The temperature plummeted, electromagnetic fields disrupted my equipment, and I felt a distinct presence working alongside me, invisible hands guiding my medical interventions. The trauma bay equipment began coordinated supernatural activity. Ventilators adjusted settings I hadn't programmed while monitors displayed readings that guided my treatment decisions. This wasn't malfunction, it was expert medical assistance. I saw her translucent reflection in the monitor screen. EMT Sarah Chen in her 1987 uniform, working desperately beside me to stabilize the patient. Then I saw her fully. A woman in her early 30s wearing a vintage EMT jacket with Chen embroidered across the chest. Her determined expression and professional movements indicated she was still trying to save lives, decades after her death. Sarah's spirit touched my hand directly, her cold fingers guiding mine to find a pulse I had missed. The touch was real, solid, and impossibly cold. Through the patient monitor displays, she communicated her story. EMT Sarah Chen had died trying to save 6 trauma victims in 1987. Her medical mission continued after death because she couldn't accept losing patients. She was using supernatural abilities to assist current medical emergencies, but modern technology confused her 1980s training. Every piece of equipment in the trauma bay responded to Sarah's spirit. Ventilators, monitors, IV pumps, and defibrillators working in perfect coordination to save the patient's life. I learned Sarah had died from internal bleeding in this exact bed while refusing treatment so doctors could focus on her patients. Her final words were, "Save them first." The supernatural truth was Sarah's unfinished mission. EMT Sarah Chen had died from internal injuries in bed 4 while insisting doctors prioritize her trauma patients. Her professional commitment was so strong that death couldn't stop her from saving lives. Sarah's final moments were spent watching her patients die one by one due to 1987's limited medical technology, equipment failures that modern medicine could have prevented. Sarah explained her supernatural perspective through monitor displays and equipment responses. She was assisting current emergencies because her EMT training demanded patient advocacy and life-saving intervention. Modern medical advances amazed her, but her core purpose remained unchanged. Sarah's spirit showed confusion and wonder at modern medical technology. Defibrillators that could restart hearts she couldn't save, monitors that could detect problems she missed, and treatments that didn't exist in 1987. The supernatural manifestations were her attempts to provide expert pre-hospital care using outdated protocols. She didn't understand current medical procedures and was frustrated by her inability to properly assist modern emergency medicine. Resolving Sarah's supernatural situation required an approach that honored her EMT service while addressing current medical needs. I established communication that acknowledged her life-saving dedication and provided closure for her unfinished mission. Sarah's spirit tested my commitment by creating a final equipment malfunction during a real emergency, watching to see if I would honor her medical expertise. By explaining modern emergency medicine through equipment demonstrations, I helped Sarah understand current trauma protocols. Her 1987 EMT knowledge was acknowledged and respected, but current patients needed contemporary care. Sarah found peace when she realized modern medicine could save the patients she couldn't. The trauma bay equipment performed one final synchronized activation, a gentle, rhythmic pattern like a heartbeat. Before returning to normal function, Sarah's spirit finally at rest. The medical equipment returned to standard operation, and Trauma Bay 4 felt warm again. A small memorial plaque was installed recognizing EMT Sarah Chen's service and sacrifice in saving lives. It's been 6 months since my encounter with Sarah's spirit. The Trauma Bay operates normally, but I've developed enhanced sensitivity to supernatural presences in medical settings. My approach to emergency medicine now includes awareness of the dedicated professionals who came before me. Sometimes during difficult emergencies, I feel a gentle presence guiding my hands. Sarah's spirit occasionally returns to assist with particularly challenging cases. I continue my nursing role with a changed perspective about the hospital's spiritual history. The experience taught me that professional dedication to saving lives can transcend death itself, and medical care sometimes extends beyond the boundaries of life and death. I work as an internist at Metropolitan Medical Center, a 450-bed facility that's been serving Los Angeles since 1965. During day shift, it's organized chaos. But after 11 p.m., the hallways stretch longer, the fluorescent lights flicker more, and every sound echoes like a warning. The internal medicine ward where this happened is on the 7th floor. Built in 1965, it has that institutional smell, disinfectant mixed with something older, something that won't wash away. The patient rooms have cardiac monitors that should only activate when patients need them, should being the key word. During night shift, we run with minimal staff, 2 doctors covering 40 patients. The telemetry system monitors everything automatically, so when alarms go off, there's usually a medical reason, usually. 11:23 p.m., I was reviewing lab results when the cardiac monitor in room 712 started displaying heart rhythms from the empty private room. At first I thought signal interference. In hospitals, electronic malfunctions happen, but the monitor showed a perfect sinus rhythm at 68 beats per minute. The EKG leads weren't connected to any patient, just coiled neatly on the empty bed. I checked the telemetry system and found no registered patient for room 712. The monitor displayed not just heart rhythm, but complete vital signs. Blood pressure 120/80, temperature 98.6 degrees Fahrenheit, oxygen saturation 99%, as if monitoring a perfectly healthy invisible patient. I documented everything: disconnected leads, empty room registry, phantom vital signs. According to hospital protocol, I should have called biomedical engineering, but the readings indicated a stable patient who didn't exist. The cardiac monitor suddenly showed ventricular fibrillation, a fatal heart rhythm, triggering the code blue alarm, then immediately returned to normal sinus rhythm, as if someone had been resuscitated. Over the next month, the incidents intensified. What started as one monitor became multiple rooms displaying phantom patients. I began documenting everything with detailed medical notes, but the supernatural presence seemed to know when I was observing. Room 712's temperature would drop precisely when the phantom heartbeat appeared, and I could see my breath in the cold air while writing medical observations. Other staff reported corroborating incidents. Nurse Rodriguez mentioned hearing medical terminology whispered in empty rooms, and Dr. Patel had witnessed IV pumps administering medications to invisible patients. The pattern affected rooms 710, 712, and 714 consistently. During patient rounds, the automated medication dispenser in room 712 suddenly ejected pills onto the empty bed, as if someone invisible was receiving their prescribed medications. The most disturbing escalation was synchronized vital sign displays. During 2:15 a.m., monitors in 3 empty rooms showed identical medical emergencies simultaneously while I was making rounds alone. This violated medical logic and created multiple code blue alarms. I felt invisible eyes watching me during medical documentation, and cold air would move past me in the hallway, as if someone was walking alongside me during night rounds. I started tracking the supernatural pattern using medical charts. The activity followed hospital schedules, always during night shift change at 11:23 p.m., always affecting rooms ending in even numbers. The computer systems recorded impossible patient data suggesting admissions that existed only digitally. Hospital security footage showed me interacting with empty rooms, but the medical equipment detected vital signs and bodily functions from invisible patients. I consulted hospital records and discovered disturbing history. The 7th floor had been the site of a deadly infection outbreak in 1982. Previous incident reports mentioned similar monitor malfunctions that were officially dismissed as electromagnetic interference. Every night shift, I felt observed during my medical documentation. The supernatural presence seemed aware of my investigation, causing equipment to malfunction whenever I approached the truth. The breakthrough came when I accessed archived medical files and found crucial evidence. Dr. Margaret Walsh had died on the 7th floor during the 1982 outbreak. Her final medical notes described her refusing to evacuate while treating infected patients, ultimately contracting the disease herself. While reading Dr. Walsh's file, every monitor on the 7th floor simultaneously displayed Dr. Margaret Walsh, attending physician, before returning to normal operation. When I reported the supernatural evidence to Chief of Medicine Dr. Harrison, his response was professional skepticism. Medical Director Thompson insisted the incidents were exhaustion-induced hallucinations and warned me about professional consequences of spreading paranormal claims in a medical facility. After the official denial, supernatural activity increased dramatically. Medical equipment in empty rooms would activate whenever hospital administrators conducted inspections. Hospital policy prevented paranormal investigation, but the supernatural activity was affecting patient care and medical documentation. Equipment continued impossible behavior despite complete system upgrades and electromagnetic shielding installation. The entity's reaction to institutional denial was professional indignation. Dr. Walsh's presence became more assertive, causing monitors to display medical diagnoses and treatment recommendations whenever administrators ignored the supernatural evidence. The administration's denial only seemed to strengthen the supernatural consequences. Escalated activity suggested Dr. Walsh was frustrated by the lack of recognition for her continued medical practice. A real medical emergency forced a direct encounter with Dr. Walsh's spirit. I was treating a patient with cardiac arrest in room 712 when the supernatural presence assisted my medical intervention. The temperature dropped dramatically, electromagnetic fields interfered with my equipment, and I felt a distinct medical presence working alongside me, invisible hands assisting with patient care. The medical equipment began coordinated supernatural activity. Monitors adjusted settings I hadn't programmed while displaying diagnostic information that guided my treatment decisions. This wasn't malfunction, it was expert medical consultation. I saw her reflection in the cardiac monitor screen. Dr. Margaret Walsh, in her 1982 white coat, working professionally beside me to save the patient's life. Then I saw her completely. A woman in her 50s, wearing a vintage physician's coat with M. Walsh, MD, embroidered on the pocket. Her clinical expertise and methodical approach indicated she was still practicing medicine decades after her death. Dr. Walsh's spirit placed her cold hand on my stethoscope, guiding me to hear a heart murmur I had missed. Her touch was solid, professional, and impossibly cold. Through the patient monitors, she communicated her medical history. Dr. Margaret Walsh had died treating patients during the 1982 infection outbreak. Her medical mission continued after death because she couldn't abandon her patients. She was using supernatural abilities to continue practicing internal medicine, but modern procedures confused her 1980s training. Every piece of medical equipment on the 7th floor responded to Dr. Walsh's spirit. Monitors, IV pumps, medication dispensers, and diagnostic equipment working in perfect medical coordination. I learned Dr. Walsh had died from the same infection she was treating, having worked 72 consecutive hours without rest during the outbreak. Her final medical note read, "Patient care before personal safety." The supernatural truth was Dr. Walsh's unfinished medical practice. Dr. Margaret Walsh had died from nosocomial infection while refusing evacuation during the 1982 outbreak. Her professional commitment was so strong that death couldn't stop her from treating patients. Dr. Walsh's final moments were spent writing medical orders for patients she knew she would never see recover, treatment plans completed despite her own declining health. Dr. Walsh explained her supernatural perspective through monitor displays and equipment responses. She was continuing medical practice because her physician's oath demanded patient care and clinical excellence. Modern medical advances fascinated her, but her core medical principles remained unchanged. Dr. Walsh's spirit showed amazement at modern diagnostic technology, monitors that could detect conditions she missed, treatments that didn't exist in 1982, and medications that could cure diseases that killed her patients. The supernatural manifestations were her attempts to provide expert internal medicine using outdated protocols. She didn't understand current medical procedures and was frustrated by her inability to properly practice modern medicine. Resolving Dr. Walsh's supernatural situation required an approach that honored her medical service while addressing current patient care needs. I established communication that acknowledged her clinical expertise and provided closure for her unfinished medical practice. Dr. Walsh's spirit tested my medical knowledge by creating a final diagnostic challenge, observing whether I would honor her clinical expertise and medical methodology. By demonstrating modern internal medicine through equipment tutorials, I helped Dr. Walsh understand current diagnostic and treatment protocols. Her 1982 medical knowledge was acknowledged and respected, but current patients needed contemporary care. Dr. Walsh found peace when she realized modern medicine could cure the diseases that killed her patients. The medical equipment performed one final coordinated sequence, displaying perfect vital signs in rhythmic harmony. before returning to normal function. Dr. Walsh's spirit finally at rest. The medical equipment returned to standard operation, and the 7th floor felt warm again. A memorial plaque was installed recognizing Dr. Margaret Walsh's service and sacrifice in treating patients during the 1982 outbreak. It's been 8 months since my encounter with Dr. Walsh's spirit. The 7th floor operates normally, but I've developed enhanced awareness of supernatural presences in medical settings. My approach to internal medicine now includes respect for the dedicated physicians who practiced before me. Sometimes during complex diagnoses, I sense a gentle presence guiding my clinical reasoning. Dr. Walsh's spirit occasionally returns to assist with particularly challenging medical cases. I continue my medical practice with a changed perspective about the hospital's professional legacy. The experience taught me that dedication to patient care can transcend death itself, and medical service sometimes extends beyond the boundaries of life and death. I work as a radiologic technologist at Riverside General Hospital, a 280-bed facility that's been serving Portland since 1948. During day shift, it's organized chaos, but after 11 p.m., the hallways stretch longer, the fluorescent lights flicker more, and every sound echoes like a warning. The radiology department where this happened is in the basement level B2. Built in 1948, it has that institutional smell, disinfectant mixed with something older, something that won't wash away. The X-ray machines have safety interlocks that should only activate when patients are positioned for imaging. Should being the key word. During night shift, we run with minimal staff, one technologist covering emergency imaging requests. The digital imaging systems monitor everything automatically, so when machines activate, there's usually a medical reason. Usually. 1:15 a.m. I was processing CT scans when X-ray machine number 3 activated automatically in the empty exam room. At first I thought automatic calibration. In hospitals, imaging equipment runs self-diagnostics, but the machine had completed a full chest X-ray exposure cycle. The digital detector showed a perfect posterior-anterior chest image of lungs, heart, and ribs, but no patient had been positioned. I checked the radiation logs and found a complete imaging sequence recorded. The X-ray image showed anatomically perfect human lungs with a small opacity in the right lower lobe, a medical finding that suggested early pneumonia in a patient who wasn't there. I documented everything: empty exam room, complete imaging cycle, diagnostic quality radiograph of invisible patient. According to hospital protocol, I should have called the physics department, but the image showed pathology requiring medical interpretation. The automatic film processor suddenly ejected a physical X-ray film showing the same phantom chest image, dropping it onto the floor with a loud clatter in the silent basement. Over the next 3 weeks, the incidents intensified. What started as one X-ray became multiple imaging modalities capturing invisible patients. I began documenting everything with radiation exposure logs, but the supernatural presence seemed to know when I was monitoring. The basement temperature would plummet during phantom imaging sessions, and I could see frost forming on the X-ray equipment despite the climate control system. Other staff reported similar experiences. Night Security Officer Johnson mentioned hearing X-ray machine movements from the basement when no technologist was scheduled, and maintenance worker Davis had witnessed CT scanners running full protocols with no patients. The pattern affected all imaging equipment systematically. During my rounds, the MRI machine suddenly powered up and began its loud scanning sequence, the magnetic field activating with thunderous noise in the empty basement. The most disturbing escalation was synchronized imaging across all modalities. During 2:30 a.m., X-ray, CT, MRI, and ultrasound machines activated simultaneously while I was alone in the department. This violated radiation safety protocols and created overwhelming mechanical noise. I felt invisible presence moving between imaging rooms, and cold air currents would follow me through the basement corridors, as if someone was being transported on stretchers I couldn't see. I started tracking the supernatural pattern using radiation exposure records. The activity followed precise timing, always between 1:15 a.m. and 3:45 a.m., always producing diagnostic quality images. The digital systems recorded impossible patient data suggesting imaging studies that existed only electronically. Radiation detection badges showed exposure readings from phantom imaging sessions, proving that actual X-rays were being generated for invisible patients. I consulted hospital records and discovered disturbing history. The basement radiology department had been the site of a radiation accident in 1963. Previous incident reports mentioned similar equipment malfunctions that were officially dismissed as electrical problems. Every night shift, I felt observed during my documentation. The supernatural presence seemed aware of my investigation, causing imaging equipment to malfunction whenever I approached the truth about the 1963 incident. The breakthrough came when I accessed archived accident reports and found crucial evidence. Radiologic technologist Robert Martinez had died from acute radiation exposure in the basement during the 1963 accident. His final duty log described him staying after hours to complete emergency imaging studies despite equipment malfunctions. While reading Robert's accident report, every imaging machine in the basement simultaneously displayed Robert Martinez, technologist, on their monitors before shutting down completely. When I reported the supernatural evidence to Radiology Director Dr. Kim, her response was immediate concern about radiation safety violations. Safety Officer Williams insisted the incidents were equipment malfunctions and warned me about professional consequences of suggesting paranormal activity with ionizing radiation. After the official denial, supernatural activity escalated dangerously. Imaging machines would activate simultaneously whenever radiation safety inspectors visited the basement. Hospital policy prevented paranormal investigation, but the supernatural activity was affecting radiation safety and imaging protocols. Equipment continued impossible behavior despite complete electrical inspections and radiation shielding verification. The entity's reaction to institutional denial was protective anger. Robert's presence became more aggressive, causing machines to produce images with radiation dose levels that spelled out "help patients" across multiple exposures. The administration's denial only seemed to increase the supernatural consequences. Escalated activity suggested Robert was frustrated by the lack of recognition for his continued attempts to provide medical imaging. A real imaging emergency forced a direct encounter with Robert's spirit. I was processing a trauma patient's CT scan when the supernatural presence assisted my technical work. The basement temperature dropped dramatically, electromagnetic fields interfered with imaging equipment, and I felt a distinct technical presence working alongside me, invisible hands adjusting imaging parameters. The radiology equipment began coordinated supernatural activity. Machines adjusted settings I hadn't programmed while producing images with perfect technical quality. This wasn't malfunction, it was expert radiologic assistance. I saw his reflection in the CT monitor screen, Robert Martinez in his 1963 lead apron, working methodically beside me to optimize the imaging study. Then I saw him fully. A man in his 30s wearing a vintage radiation protection apron with R. Martinez, RadTech on the name tag. His precise technical movements and attention to detail indicated he was still performing medical imaging decades after his death. Robert's spirit guided my hands to adjust the X-ray beam angle, his cold fingers overlapping mine on the equipment controls. The touch was solid, professional, and impossibly cold. Through the imaging monitors, he communicated his story. Radiologic technologist Robert Martinez had died from radiation exposure while completing emergency imaging studies in 1963. His technical mission continued after death because he couldn't leave patients without diagnostic imaging. He was using supernatural abilities to assist current radiology work, but modern digital technology confused his analog training. Every piece of imaging equipment in the basement responded to Robert's spirit. X-ray machines, CT scanners, MRI systems, and ultrasound units working in perfect technical coordination. I learned Robert had died from acute radiation syndrome caused by staying after hours to image emergency patients despite equipment safety warnings. His final log entry read, "Patient care requires complete imaging studies." The supernatural truth was Robert's unfinished technical mission. Radiologic technologist Robert Martinez had died from radiation exposure while completing emergency imaging studies in 1963. His professional commitment was so strong that death couldn't stop him from providing medical imaging. Robert's final moments were spent positioning patients for X-rays despite increasing radiation exposure, technical dedication that ultimately killed him while serving others. Robert explained his supernatural perspective through monitor displays and equipment responses. He was continuing imaging work because his technologist oath demanded accurate diagnostics and patient service. Modern digital systems amazed him, but his core technical principles remained unchanged. Robert's spirit showed fascination with modern imaging technology, digital detectors that replaced film, CT scanners that could see inside bodies, and MRI systems that didn't exist in 1963. The supernatural manifestations were his attempts to provide expert technical imaging using outdated analog methods. He didn't understand current digital procedures and was frustrated by his inability to properly operate modern equipment. Resolving Robert's supernatural situation required an approach that honored his technical service while addressing current imaging needs. I established communication that acknowledged his radiologic expertise and provided closure for his unfinished technical mission. Robert's spirit tested my technical knowledge by creating a final imaging challenge, observing whether I would honor his expertise and commitment to diagnostic quality. By demonstrating modern digital imaging through equipment tutorials, I helped Robert understand current radiologic technology. His 1963 technical knowledge was acknowledged and respected, but current patients needed contemporary imaging. Robert found peace when he realized modern equipment could provide better diagnostics than his analog systems. The imaging equipment performed one final coordinated sequence, displaying perfect technical parameters across all modalities. Before returning to normal function, Robert's spirit finally at rest. The imaging equipment returned to standard operation, and the basement felt warm again. A memorial plaque was installed recognizing Robert Martinez's service and sacrifice in providing medical imaging. It's been 4 months since my encounter with Robert's spirit. The radiology department operates normally, but I've developed enhanced sensitivity to supernatural presences in technical environments. My approach to medical imaging now includes respect for the dedicated technologists who worked before me. Sometimes, during complex imaging procedures, I sense a gentle presence guiding my technical settings. Robert's spirit occasionally returns to assist with particularly challenging radiologic cases. I continue my technologist role with a changed perspective about the department's technical legacy. The experience taught me that dedication to diagnostic imaging can transcend death itself, and technical service sometimes extends beyond the boundaries of life and death. I work as a clinical pharmacist at Cancer Treatment Center of Excellence, a 200-bed oncology facility that's been serving San Francisco since 1971. During day shift, it's organized chaos, but after 11 p.m., the hallways stretch longer, the fluorescent lights flicker more, and every sound echoes like a warning. The chemotherapy unit where this happened is on the 3rd floor. Built in 1971, it has that institutional smell, disinfectant mixed with something older, something that won't wash away. The automated dispensing systems have safety protocols that should only activate when pharmacists authorize medication access. Should being the key word. During night shift, we run with minimal staff, one pharmacist covering medication orders for the entire oncology unit. The computerized systems track everything automatically, so when dispensers activate, there's usually a prescription reason. Usually. 10:45 p.m. I was reviewing chemotherapy protocols when the automated dispensing system in Station C activated without authorization. At first, I thought system glitch. In hospitals, computerized equipment occasionally malfunctions, but the dispenser had completed a full medication cycle. The system logs showed dispensing doxorubicin, cyclophosphamide, and fluorouracil, a complete chemotherapy regimen, but no patient order existed. I checked the pharmacy database and found no prescription records. The dispensing records showed precise dosing calculations based on body surface area of 1.7 m², mathematical precision suggesting a specific patient who wasn't in our system. I documented everything. Unauthorized dispensing, complete chemotherapy regimen, calculated dosages for phantom patient. According to hospital protocol, I should have called security, but the medications indicated someone needed life-saving cancer treatment. The IV preparation hood suddenly activated with sterile airflow, and I watched invisible hands apparently preparing chemotherapy infusions, syringes moving and solutions mixing by themselves. Over the next 6 weeks, the incidents intensified. What started as one dispensing event became multiple automated systems preparing complete treatment protocols. I began documenting everything with pharmacy logs, but the supernatural presence seemed to know when I was observing. The medication preparation area temperature would drop precisely during phantom dispensing events, and I could see frost forming on the sterile preparation equipment. Other staff reported corroborating incidents. Oncology nurse Williams mentioned finding prepared chemotherapy bags that weren't ordered, and Dr. Patel had witnessed IV pumps programming themselves with treatment protocols. The pattern affected the entire chemotherapy unit systematically. During my medication checks, the chemical safety shower suddenly activated, drenching the preparation area as if someone invisible had been exposed to hazardous chemicals. The most disturbing escalation was synchronized dispensing across all stations. During 11:30 p.m., every automated system activated simultaneously, preparing complete cancer treatment regimens while I was alone in the pharmacy. This violated pharmaceutical safety protocols and wasted thousands of dollars in chemotherapy drugs. I felt invisible presence moving through the preparation area, and cold air would follow me through the pharmacy. As if someone was checking medication orders I couldn't see. I started tracking the supernatural pattern using dispensing logs. The activity followed treatment schedules, always during night shift, always preparing complete chemotherapy protocols. The computer systems recorded impossible prescription data, suggesting cancer patients who existed only electronically. Pharmaceutical tracking systems showed medication usage for ghost patients with detailed treatment histories, but no actual medical records. I consulted hospital records and discovered disturbing history. The chemotherapy unit had been the site of a medication error tragedy in 1978. Previous incident reports mentioned similar dispensing malfunctions that were officially dismissed as computer glitches. Every night shift, I felt observed during my documentation. The supernatural presence seemed aware of my investigation, causing dispensing systems to malfunction whenever I approached the truth about the 1978 tragedy. The breakthrough came when I accessed archived pharmaceutical records and found crucial evidence. Clinical pharmacist Dr. Linda Thompson had died by suicide in the pharmacy after accidentally causing a patient's death through a dosing calculation error in 1978. Her final pharmacy notes described her devastating guilt over the fatal mistake. While reading Dr. Thompson's file, every dispensing system in the pharmacy simultaneously displayed Dr. Linda Thompson, clinical pharmacist, before shutting down completely. When I reported the supernatural evidence to pharmacy director Dr. Roberts, his response was immediate concern about drug diversion and security breaches. DEA compliance officer Martinez insisted the incidents were sophisticated theft attempts and warned me about professional consequences of suggesting paranormal activity with controlled substances. After the official denial, supernatural activity escalated dangerously. Dispensing systems would activate simultaneously whenever pharmacy inspectors visited the unit. Hospital policy prevented paranormal investigation, but the supernatural activity was affecting medication safety and drug inventory. Equipment continued impossible behavior, despite complete system security upgrades and biometric access installation. The entity's reaction to institutional denial was desperate urgency. Dr. Thompson's presence became more aggressive, causing systems to prepare increasingly complex chemotherapy regimens, with notes spelling out "must save them" across dispensing logs. The administration's denial only seemed to increase the supernatural consequences. Escalated activity suggested Dr. Thompson was driven by overwhelming guilt to prevent any patient deaths. A real medication emergency forced a direct encounter with Dr. Thompson's spirit. I was preparing emergency chemotherapy for a critical patient when the supernatural presence assisted my pharmaceutical work. The pharmacy temperature dropped dramatically, electromagnetic fields interfered with dispensing equipment, and I felt a distinct pharmaceutical presence working alongside me, invisible hands calculating dosages and checking my work. The dispensing systems began coordinated supernatural activity. Machines adjusted calculations I hadn't programmed while displaying dosing information that improved my preparation accuracy. This wasn't malfunction, it was expert pharmaceutical consultation. I saw her reflection in the computer screen, Dr. Linda Thompson in her 1978 lab coat, working meticulously beside me to ensure medication safety. Then I saw her completely. A woman in her 40s wearing a vintage pharmacist coat with L. Thompson, PharmD, on the name tag. Her precise attention to detail and triple-checking behavior indicated she was still preventing medication errors decades after her death. Dr. Thompson's spirit guided my hands during dosage calculations, her cold fingers overlapping mine on the computer keyboard. The touch was solid, professional, and impossibly cold. Through the dispensing system displays, she communicated her story. Clinical pharmacist Dr. Linda Thompson had died by suicide after a fatal dosing error killed a pediatric cancer patient in 1978. Her pharmaceutical mission continued after death because she couldn't bear causing another patient's death. She was using supernatural abilities to assist current medication preparation, ensuring perfect accuracy to prevent any repeat of her tragic mistake. Every piece of dispensing equipment in the pharmacy responded to Dr. Thompson's spirit. Automated systems, IV pumps, computer terminals, and safety equipment working in perfect pharmaceutical coordination. I learned Dr. Thompson had calculated the wrong dose for a 6-year-old leukemia patient, causing fatal toxicity. Her final note read, "I cannot live with this mistake." The supernatural truth was Dr. Thompson's unfinished mission of medication safety. Clinical pharmacist Dr. Linda Thompson had died by suicide after a fatal dosing calculation error killed a pediatric patient in 1978. Her professional commitment was so strong that death couldn't stop her from preventing medication errors. Dr. Thompson's final moments were spent reviewing every calculation she had ever made, tormented by the mathematical mistake that killed an innocent child. Dr. Thompson explained her supernatural perspective through computer displays and equipment responses. She was obsessively checking current pharmaceutical work because her professional oath demanded patient safety and error prevention. Modern computerized systems amazed her, but her core pharmaceutical principles remained unchanged. Dr. Thompson's spirit showed fascination with modern pharmacy technology, automated dose checking that could prevent her mistake, electronic systems that verified calculations, and safety protocols that didn't exist in 1978. The supernatural manifestations were her attempts to provide expert pharmaceutical care using obsessive accuracy. She didn't understand current automated safety systems and was driven by paralyzing fear of repeating her fatal error. Resolving Dr. Thompson's supernatural situation required an approach that honored her pharmaceutical expertise while addressing her overwhelming guilt. I established communication that acknowledged her dedication to medication safety and provided forgiveness for her unintended mistake. Dr. Thompson's spirit tested my pharmaceutical knowledge by creating a final calculation challenge, observing whether I would honor her commitment to patient safety. By demonstrating modern pharmaceutical safety systems, I helped Dr. Thompson understand that current technology could prevent her type of error. Her pharmaceutical expertise was acknowledged and respected, and I assured her that her mistake led to safety improvements that saved countless lives. Dr. Thompson found peace when she realized her death had meaningful purpose in advancing medication safety. The dispensing equipment performed one final coordinated sequence, displaying perfect pharmaceutical calculations across all systems. Before returning to normal function, Dr. Thompson's spirit finally at rest. The dispensing equipment returned to standard operation, and the pharmacy felt warm again. A memorial plaque was installed recognizing Dr. Linda Thompson's contribution to pharmaceutical safety and patient care. It's been 7 months since my encounter with Dr. Thompson's spirit. The pharmacy operates normally, but I've developed enhanced sensitivity to supernatural presences in pharmaceutical environments. My approach to medication preparation now includes respect for the dedicated pharmacists who worked before me. Sometimes during complex dosing calculations, I sense a gentle presence guiding my mathematical work. Dr. Thompson's spirit occasionally returns to assist with particularly challenging pharmaceutical cases. I continue my pharmacist role with a changed perspective about the profession's responsibility for patient safety. The experience taught me that dedication to preventing medication errors can transcend death itself, and pharmaceutical service sometimes extends beyond the boundaries of life and death. I work as a pediatric nurse at Children's Memorial Hospital, a 150-bed facility that's been serving Dallas since 1955. During day shift, it's organized chaos. But after 11 p.m., the hallways stretch longer, the fluorescent lights flicker more, and every sound echoes like a warning. The pediatric ICU where this happened is on the 4th floor. Built in 1955, it has that institutional smell, disinfectant mixed with something older, something that won't wash away. The infant monitoring systems have alarms that should only activate when babies need immediate attention, should being the key word. During night shift, we run with minimal staff, 2 nurses covering 12 critically ill children. The automated monitoring systems track everything continuously, so when alarms sound, there's usually a medical emergency. Usually. 12:30 a.m., I was charting medication administration when the infant monitor in bed 8 started alarming from the empty isolation room. At first, I thought sensor malfunction. In pediatric units, equipment sensitivity causes frequent false alarms. But the monitor displayed complete vital signs for a newborn. Heart rate 140, respiratory rate 45, temperature 98.2 degrees or Fahr, oxygen saturation 97%. The isolette was empty, but the warming lights were activated and the humidity controls were running. I checked the patient census and found no infant assigned to bed 8. The monitoring system showed detailed physiological data. Weight 6 pounds 2 ounces, gestational age 35 weeks, as if caring for a premature baby who wasn't there. I documented everything: empty isolette, complete neonatal monitoring, phantom infant vital signs. According to hospital protocol, I should have called biomedical engineering, but the readings indicated a stable premature infant requiring specialized care. The automatic feeding pump suddenly activated, dispensing breast milk into an empty bottle, the mechanical sound echoing through the quiet PICU. Over the next month, the incidents intensified. What started as one isolette became multiple beds caring for invisible infants. I began documenting everything with nursing notes, but the supernatural presence seemed to know when I was observing. The isolation room temperature would regulate automatically during phantom monitoring events, maintaining precise neonatal thermoregulation. Other staff reported corroborating incidents. Night nurse Jackson mentioned hearing infant crying from empty rooms, and Dr. Martinez had witnessed ventilators providing respiratory support to invisible babies. The pattern affected the entire PICU systematically. During my rounds, the phototherapy lights suddenly illuminated bed 8, treating invisible jaundice in the empty isolette. The most disturbing escalation was synchronized alarms across all neonatal monitors. During 1:45 a.m., every isolette displayed critical vital signs simultaneously while I was alone in the unit. This violated pediatric safety protocols and created overwhelming alarm fatigue. I felt invisible presence moving between isolettes, and warm air would circulate around me in the unit, as if someone was checking on sleeping babies I couldn't see. I started tracking the supernatural pattern using nursing documentation. The activity followed PICU schedules, always during night shift, always caring for premature infants. The monitoring systems recorded impossible patient data suggesting neonatal admissions that existed only electronically. Pediatric tracking systems showed detailed infant care records with feeding schedules, medication administration, and developmental milestones for babies who had no medical records. I consulted hospital records and discovered disturbing history. The PICU had been the site of a devastating fire in 1972 that killed several premature infants. Previous incident reports mentioned similar monitoring malfunctions that were officially dismissed as electrical problems. Every night shift, I felt observed during my documentation. The supernatural presence seemed aware of my investigation, causing monitoring equipment to malfunction whenever I approached the truth about the 1972 fire. The breakthrough came when I accessed archived incident reports and found crucial evidence. Pediatric nurse Mary Sullivan had died in the PICU during the 1972 fire while trying to evacuate premature infants from the burning unit. Her final nursing notes described her refusing to leave until every baby was safe. While reading Mary's file, every infant monitor in the PICU simultaneously displayed Mary Sullivan, pediatric nurse, before returning to normal operation. When I reported the supernatural evidence to Nurse Manager Williams, her response was immediate concern about patient safety and false alarms. Risk Management Director Thompson insisted the incidents were equipment sensitivity issues and warned me about professional consequences of spreading paranormal claims in a pediatric facility. After the official denial, supernatural activity increased dramatically. Monitoring systems would alarm simultaneously whenever hospital administrators toured the PICU. Hospital policy prevented paranormal investigation, but the supernatural activity was affecting patient care and alarm response protocols. Equipment continued impossible behavior despite complete system calibration and sensitivity adjustments. The entity's reaction to institutional denial was maternal protectiveness. Mary's presence became more assertive, causing monitors to display increasingly urgent alarm patterns with messages spelling out "protect babies" across multiple screens. The administration's denial only seemed to strengthen the supernatural consequences. Escalated activity suggested Mary was driven by overwhelming maternal instinct to protect all infants. A real pediatric emergency forced a direct encounter with Mary's spirit. I was caring for a critically ill premature infant when the supernatural presence joined me in providing life-saving care. The PICU temperature regulated perfectly, electromagnetic fields stabilized my equipment, and I felt a distinct nursing presence working alongside me, invisible hands assisting with delicate infant care. The neonatal equipment began coordinated supernatural activity. Monitors adjusted settings I hadn't programmed while displaying vital information that guided my nursing interventions. This wasn't malfunction. It was expert pediatric nursing assistance. I saw her reflection in the monitor screen, Mary Sullivan in her 1972 nursing uniform, working gently beside me to care for the fragile infant. Then I saw her completely. A woman in her 30s, wearing a vintage nurse's cap and starched white uniform with M. Sullivan, RN, on the name pin. Her gentle touch and protective instincts indicated she was still caring for babies decades after her death. Mary's spirit guided my hands during infant assessment, her warm fingers overlapping mine as we checked the baby's breathing. The touch was solid, caring, and surprisingly warm. Through the monitoring displays, she communicated her story. Pediatric nurse Mary Sullivan had died in the 1972 fire while carrying premature infants to safety, saving 12 babies before succumbing to smoke inhalation. Her nursing mission continued after death because she couldn't bear leaving babies unprotected. She was using supernatural abilities to monitor current PICU patients, ensuring every infant received the protective care she couldn't provide to those lost in the fire. Every piece of neonatal equipment in the PICU responded to Mary's spirit. Isolates, monitors, ventilators, and feeding systems working in perfect maternal coordination. I learned Mary had died carrying her 13th baby toward the exit, both perishing just feet from safety. Her final words were, "Save the babies first." The supernatural truth was Mary's unfinished maternal mission. Pediatric nurse Mary Sullivan had died protecting premature infants during the 1972 fire. Her maternal instincts so strong that death couldn't stop her from caring for babies. Mary's final moments were spent ensuring infant safety despite mortal danger, nursing dedication that ultimately cost her life while saving others. Mary explained her supernatural perspective through monitored displays and gentle equipment responses. She was continuing infant care because her nursing heart demanded protection of the most vulnerable patients. Modern neonatal technology amazed her, but her core maternal principles remained unchanged. Mary's spirit showed wonder at modern pediatric equipment, advanced monitors that could detect problems she missed, life support systems that could save babies she lost, and treatments that didn't exist in 1972. The supernatural manifestations were her attempts to provide expert neonatal care using protective instincts. She didn't understand current technology but was driven by overwhelming need to ensure no baby ever felt alone or unprotected. Resolving Mary's supernatural situation required an approach that honored her nursing dedication while addressing her protective concerns. I established communication that acknowledged her maternal sacrifice and provided assurance that current babies were safe. Mary's spirit tested my commitment by creating a final monitoring challenge, observing whether I would honor her protective instincts and dedication to infant care. By demonstrating modern neonatal care through equipment education, I helped Mary understand that current technology could protect babies better than 1972 methods. Her nursing expertise was acknowledged and respected, and I assured her that her sacrifice inspired improved fire safety that protected countless infants. Mary found peace when she realized modern PICU safety could prevent tragedies like the 1972 fire. The neonatal equipment performed one final coordinated sequence, displaying gentle, rhythmic patterns like sleeping babies breathing. Before returning to normal function, Mary's spirit finally at rest. The monitoring equipment returned to standard operation, and the PICU felt warmly protective again. A memorial garden was created recognizing Mary Sullivan's sacrifice and dedication to protecting premature infants. It's been 10 months since my encounter with Mary's spirit. The PICU operates normally, but I've developed enhanced sensitivity to supernatural presences in pediatric environments. My approach to neonatal nursing now includes awareness of the protective spirits who watch over vulnerable children. Sometimes during difficult infant emergencies, I feel a warm presence guiding my hands. Mary's spirit occasionally returns to assist with particularly fragile babies. I continue my pediatric nursing with a changed perspective about the maternal nature of infant care. The experience taught me that dedication to protecting children can transcend death itself, and nursing love sometimes extends beyond the boundaries of life and death. Phantom Whisper 01 family, I need to hear from healthcare workers who've experienced the unexplainable. Have you worked in hospitals where supernatural phenomena happened? Equipment that activated without patience, voices in empty rooms, footsteps in abandoned hallways? Share your supernatural healthcare stories in the comments, but remember patient privacy laws still apply to paranormal encounters. If this episode gets 500 comments, I'll investigate the abandoned wing of St. Augustine Medical Center and document what I find. Healthcare workers see things that would terrify the general public. Subscribe to Phantom Whisper 01 and ring that notification bell. Medicine deals with life and death every day, but sometimes death doesn't mean the end of caring for patients. Stay vigilant out there, Phantom Whisper 01 family. And remember, some hospital residents never got their discharge papers.